आप कब से लीव पे जा रही है? So ADHD, how many kids you have seen? Anyone else we are expecting to join? एग्जाम वही नहीं आएंगे? I think the theory exam 3 to 4 days की theory exams है शायद. I think अभी interns what is the time to come? आप लोग एग्जैक्ट 9 बजे आते हो? मेरे पीछे आ रहे हैं, मेरे पीछे पीछे आ रहे हैं. मेरा एहसास is on leave, huh? What was the we will start. So how many kids you have seen? कितने बच्चे देखे हैं ADHD के? हाँ, 1 or 2. सार्थक 1 or 2. What are you seeing? 3, 4. And what is shining? अच्छा ठीक है. So we if we see the timeline, no, we see that it was an entity which was subsequently worked upon in 1775, and interestingly, the person who gave this name ADHD, or subsequent or finally who actually conceptualized it, his name was George Still. So name was Still, and subsequently Still described effect of morality, and his descriptions in 1910 were most closest to the ADHD. Subsequently, ADHD was given a name which is known as minimal brain dysfunction, and also minimal brain damage first after the of the pandemic last century, and subsequently it was said that it is not a damage, it is a dysfunction. And then you can see this flow chart. Then DSM-3, DSM-4 subsequently came in. Stimulants chipped in around 60s. So stimulants was chipped in around 60s. It's a very interesting thing that stimulants were first actually were discovered as an anti-epileptics, and then they subsequently found that it improved ADHD. And in this current century, these non-stimulants got approval. So why we are studying ADHD too? Because it is something which is related to chronicity. It's a neurodevelopmental issue, but it remains with the person for a very, very long period of time. It is not correctly diagnosed by many primary care physicians, and also the American Academy of Pediatricians. They say that its screening and diagnosis is must by preschool age. So when we talk about prevalence, these are the summary of the prevalence studies. Male is more common than female. maybe it is more diagnosed in males, and the average prevalence is 3 to 7%. That is huge. If we say in India, so around 1 crore, 1.30 crore population is there, 130 crores. So 7% you calculate. So it must be in huge numbers. Now, interestingly, there is a US-UK debate. Because of the difference in diagnosis systems, they say that US has more patients with more children diagnosed with ADHD than UK. And apparently, France, they don't have any ADHD. They say that there are various hypotheses because of this. The diagnosis system used by France is different. They also say that this French kids, the parental punishment is legal there, vis-a-vis in US, where it is mostly diagnosed. The highest diagnosis of ADHD in US, where parental punishment is illegal. A child can call the police and parents can be behind the bars. So there are many hypotheses. India, as expected, it is not systematically reported. The most common reason for consultation is not hyperactivity by the parents, it is educational difficulties. And mental health team is a last resort. First, they will go to the educational institutes, then they'll go to the religious institutes, and subsequently mental health. Now, what is the time to come? I'm so sorry. What is the time? What is the time to come? You are seniors, you are expected to come early. This is embarrassing. This is little disrespecting. That so-called head of the department is giving in a lecture and you people, half of the department is joining late. Please come. Please come. So when we see core of ADHD, so we see that there are three domains of ADHD, which are basic. We have to be very, very clear with the understanding. This is inattention, impulsivity, and hyperactivity. So impulsivity and hyperactivity, they go in sync with each other. Have you heard the first years this lecture before? The second years? Have you taken this before? The third years? You've taken the same before. So repetition. So when we see a vignette, Bajrangi, he's a 7-year-old male. For the third time in past 5 minutes, fourth grade teacher had to tell him to sit in a seat, keep his hands to himself. It is as if Bajrangi feet are attached to springs. He doesn't walk, he bounces. He doesn't sit, he squirms. It's not just the motor activity that sets him apart from rest of his class. Bajrangi also has a motor mouth. He talks incessantly. He can't resist sharing his ideas with the class, whether they are welcomed or not. As soon as he thinks about them, regardless of whether the time is right, Bajrangi blurts out answers, disrupts the classroom, and adds considerable stress to the teacher's already stressful job. He would use materials from other students without asking them. Bajrangi is almost the polar opposite of his classmate Sai. Okay, we'll discuss about Bajrangi later. Sahil's antics fades into the background of other classroom stuff. Unlike Bajrangi, Sahil is very quiet, rarely participate in classroom discussions unless the discussions are something that really interests him. Sahil spends most of his time staring out of the window or off into the space. He frequently forgets his school books and school bag is messy. The word daydreamer seems to fit Sahil perfectly. He always seems to be at least one step behind everyone else. He's rarely on task. He drifts off in the middle of the assignment, which is not more than usually 10 minutes. And often he has to be reminded to return to earth. Sahil is doing poor academically. He doesn't seem to tune into the whatever channel the rest of the class is on. Initially, the teacher thought that Sahil was a slow learner until the class began to discuss different computer programs. The teacher was shocked at Sahil's sophisticated knowledge base and expertise in the area. That was when his teacher began to think that there was something else getting in the way of Sahil's academic success. So what is Bajrangi? What is Sahil? Bajrangi fits into what domains of ADHD and Sahil? Sahil, inattention, and Bajrangi, hyperactivity, impulsivity. Though it is very, very difficult at times to differentiate, but just for the basic understanding. And if these symptoms are persistent for 6 months, ये कोई parent आके कहते हैं 15 दिन से हो रहा है, we need to see whether there are other soft factors like situational change, We see a lot of students from hilly areas getting transferred to this area, change of medium, them changing from Hindi medium to English medium can make them fidgety, restless, inattentive. ऐसा तो नहीं है कि ये ट्रांजिट एडजस्टमेंट फेज था. सो 6 months से सारा सिम्टम्स होंगे. इट माइट नॉट बी रिलेटेड टू एनी स्पेसिफिक trigger or precipitating factor. Very small children, a toothache, constipation, physical problems can make them fidgety, irritable, impulsive, inattentive. So you have to see those factors also, and these symptoms should start before 12 years of age. So this is what is ADHD. And core symptoms which you see in your guidelines, you have to count those 6 out of 9 symptoms that I have not actually put up because those were mentioned in the case with just to make things interesting. Now, very important clinical point is how you actually diagnose it. You have to actually take the history from multiple sources. Now, most of the family members will take. It is a very, very poor I would say approach. कि बच्चा पेरेंट्स के साथ अंदर आया है and then you diagnose child as a diagnosis. You talk to the children's friend. You have to talk to the children's friend. You have to talk to the teacher. You know, we really do this, and otherwise you might err on the either overdiagnosing or underdiagnosing. And settings. So if it has to be more than one setting. Child may be having a disturbed home atmosphere, might be irritable, impulsive, in home, but might be enjoying in school. The children would want to go to school or play setting. So you have to see, otherwise there might be chances of wrongly diagnosing ADHD. Very basic points or very important points. And appropriateness, age appropriateness. What is the age when we can diagnose hyperactivity? Confident. What is the age of the child where we can say कि नहीं hyperactivity हम ADHD के diagnostic level दे सकते? I still remember one of the psychiatrists saying a 3-year-old child coming with hyperactivity कि नहीं जी ये बच्चा नहीं hyperactive होगा तो आप या मैं होंगे. So whether a 3-year-old child we can confidently diagnose as ADHD, it might be age appropriate hyperactivity. So it shall not be diagnosed in less than 4 years of age. So it should be a diagnosis which is kept after 4 years of age. So before 4 years of age, it becomes very difficult. Okay, and now when we see preschoolers, the children of 1, 2, 3 years of age, how they actually present. If we want to see whether now they will develop ADHD. So we see that there will be highly overactive, whirlwind. They do not listen to when called. Misdiagnosis autism. No sense of danger. Gaadi aa rahi hai, kuch bhi aa rahi hai, they'll run around. And very short play sequences, less than 3 minutes. And these references are Indian Journal of Psychiatry. There is a dossier guideline, which is a summary. I think it was published 2 years back. So I've taken everything from there. And leave activities incomplete. So when we see when they go to primary school is similar presentation as Bajrangi and Sai, 7 years and 6 years of age, that kind of a thing. And when the child becomes an adolescent, we see that there is an overactivity and a fidgetiness. We can see the opioid intake patients who come to us. They're very fidgety. They're not able to sit in one place, but very subtle level you will see that. Very importantly is impulsivity. They'll have a lot of risk-taking behaviors which push them towards these high, these illicit drugs. Inattention can manifest in a lot of presentations. Like, for example, like they can present with a lot of us among us, we may have all these procrastination. Because of inattention, they'll delay their activities. And a frequent missing of deadlines. They say that they have choice paralysis. Where a lot of choices will come, they're not able to select how to go about it. And many people say that they would hyper focus on something which interests them, and compromising focus on all the other activities which are actually required for their subsequent growth. And if all these clinical pointers, like taking history from the whole gamut of resource persons in more than one setting, an age appropriate hyperactivity, and hyperactivity which is explained at different spheres of life, causing dysfunction in at least one sphere, either academic or interpersonal or social, we say that this is diagnosis of ADHD. And then we have to actually subsequently slot them into mild, moderate, and severe. Why? Any idea? क्यों हम करेंगे? Grading is why grading is important, and we need to do this in when patient or child comes to us with ADHD. Now, important is, we'll come to this later on, why we categorize them. Important is signs of ADHD may be minimal or absent if there is one-to-one interaction. I know if I'm actually very closely interacting with a child, that I might not see the hyperactivity symptoms. हम कहें कहाँ है ADHD, कहाँ चंचल है बच्चा, तो ठीक है बिल्कुल, तो वो मिस हो जाए under close supervision, है ना, and then when supervising very closely the child. This more or less same one-to-one interaction or under close supervision, any novel situation which actually excites a child, like going to a guest where there is a playroom, you know, a novel, or coming to a clinic where there is a playroom. So they will actually get hooked on to hyper focusing into one activity and whatever interests them. So playing PUBG, so whatever actually excites them, तो वहाँ पर भी signs of ADHD में भी minimal or absent. Inattention, इसका अगर हम ऑपोजिट पोल में जाएं, ज्यादा मैनिफेस्ट कब हो सकता है? इनअटेंशन में भी ओवर इन्फ्लेटेड, हमको लगेगा कि नहीं ये तो इनअटेंशन हो रहा है, ये तो ADHD है, इट माइट नॉट बी देयर. व्हाट ऑल सिचुएशंस? सो फटीग, है ना, फटीग में हम सबका भी इनअटेंशन होता है ना, तो वी आर एक्सरसाइजिंग, वी आस्क द चाइल्ड कि आप बिजनौर से आइए जी बच्चों को दिखाने के लिए. By the time child travels 4 hours and child might be fatigued, and you actually evaluation might find child having inattention. So that can be, we need subsequent evaluations to that. Long working hours, or when you talk about adults and substance intake. So what is not ADHD? What is not ADHD? Which might actually be confused with ADHD. So one is developmentally normal children, which with age-appropriate hyperactivity is not an ADHD. Then difficult temperament of the child. In preschoolers, it's not an ADHD. That is before 6 years of age. ODD and conduct disorders, oppositional defiance and conduct disorders, at times can be misdiagnosed as ADHD. How you actually then see then that actually when we see defiance, they actually follow ADHD. You know, so if this kind of history is there, that this defiance was preceded by ADHD, so then you can give a comorbid diagnosis. But do not diagnose ADHD only in presence of defiance. So intellectual disability. So intellectual disability, IQ is compromised. So you will have inattention, difficult to follow instruction due to lack of comprehension, and so you have to actually, what you have to do is you have to calculate the mental age of the child. So you have to see whether the inattention is appropriate to the mental age of the child. The mental age is the biological age is 10 years, mental age is 7 years. So whether this inattention is equivalent to 7 years of the child mental age. Then specific learning disability or dyslexia. So where academic difficulties are persisting, which is variable in ADHD, and like ADHD child might be involved in leisure reading, so which excites him, fictional readings, and the school books might not excite, but this will not happen in specific learning disability child. He'll run away from while seeing books. Autism, where inattention and hyperactivity are mainly related to social communication and sensory issues. And then tics, we all know that they are preceded by premonitory sensations, and they are motor tics or vocal tics. And at times, you know, that the hyperactivity, we might miss the tics part of it. We need a longitudinal observation, and very commonly they are comorbid. Very, very commonly. जब भी tics का बच्चा आएगा, आप देखोगे hyperactivity मिलेगा ही मिलेगा. बहुत रेयर होगा कि नहीं मिलेगा. So क्या करना है? What differentials you need to rule out? You need to rule out thyroid disorders, very importantly, any history of head injury, any subtle seizures, and seizures manifesting as hyperactivity or inattention. So you can see there is a past history of a seizure. They gave medications for 2 years, they discontinued the medications, and you can see child actually dropping off school, becoming inattentive, poor scholastic performance, go for an evaluation. Very high chances you might find epileptic abnormalities, and if you treat them, inattention will go. Then drugs like thyroxine or the thyroid supplements. Antipsychotics can cause a lot of fidgetiness, akathisia. Bronchodilators we generally miss out. Bronchodilators can be little problematic, and isoniazid. Isoniazid is pretty notorious in causing behavioral issues. Now, this is very important. When we give stimulants, we need to see this, take this history to the children. History of any syncope, any exercise intolerance, any congenital cardiac malformations, or any cardiac surgery in the child or in the family. Why? Because stimulants can be cardiotoxic in these populations. So this is very, very important. So long before a child came, and child was put on stimulants by one of the pediatricians, and he was repeatedly falling out. So we thought that no, it might be epilepsy or underlying epilepsy worsening. It came out to be that child was having irregular heartbeats, some arrhythmias with stimulants. We removed stimulants, put him on non-stimulant and ADHD medications, and the child. So now, what investigations we will go for ADHD to establish ADHD? Clinically, आपने देख लिया, investigations there. Drugs आपने rule out कर लिए, thyroid abnormalities आपने rule out कर लिए. Neuroimaging, EEG. So no neuroimaging or EEG or ECG is recommended unless specifically indicated. So gold standard is your clinical approach. Still, gold standard is clinical approach. If you're finding something else, suspecting something else, then you have to go for an EEG. Otherwise, EEG as a routine is not indicated in ADHD as of now. There was a scenario where lead levels were suspected, toxicity was suspected, specifically in those kids who were actually living in those environments. There was expected more high lead levels, but nowadays they don't approach it. Rating scales, there are a lot of hue and cry about ADHD rating scales, ADHD rating scale, and then there are a lot of rating scales with ADHD. Venterbit is there, and SNAP is there. SNAP 4 is there, very famous rating scale. There is no role actually. They are desired but not mandatory. Gold standard again remains clinical evaluation. So this is a take-home point, I would say. So where ADHD resides in the brain? Tell me, any idea? So when we see, few people have said that it is in medial prefrontal cortex. Few people have actually, said that default mode network is involved in this. But when we see a recent meta-analysis by Samia et al., see ADHD resides in all this. All this. Where is it? So there is no localization of it. It resides in the whole of the brain. Still, we are not able to tease out where exactly is the pathology in ADHD. So this is the accumulation, there's fMRI coordinates of the studies, of all the studies till done till. So very interestingly, it is very heterogeneous. So when we see a follow-up, when we follow these children, this is a very important thing. So this inattention, it persists, but impulsivity and hyperactivity reduces. So when they go to adolescence, the inattention, inattention persists, and there might be impulsivity, and which can lead patient into. So 60 to 80% of symptoms they persist into adult. Now, so what is very, very important in treating these children when we try to find the answers? How we approach? A mild, moderate, severe we categorize. So we first of all we need to have a therapeutic alliance, a positive regard. We validate the feelings of the parents. We reach to realistic goals. बिल्कुल ठीक हो जाएगा. कोई दिक्कत नहीं. आप 3 महीने दवाई खिला. Nothing of that sort. And you have to actually see what is a child need and what's a parent's need. Child need might be that I play around, I focus more time on my games. Child is not able to do that. Parents' requirements always is education. They are only worried about academics. So you discuss with this, discussing with the extended family, calling, because parents might follow, grandparents might not follow. Our system is very diverse and very heterogeneous. So we need to go for joint treatment decisions. Need to involve them. otherwise treatment adherence might be an issue, and we need to mitigate this blame and guilt. कैसे होता है हमारी सोसाइटी में blame and guilt? I guess ना दादी जी कहती मम्मी की वजह से है, मम्मी कहती दादा पे गया. One child I got कि जैसे ही मैंने उन्हें बोला तो मैं दादा पे गया है, मदर बिगिन वेरी हैप्पी, है ना, कि हाँ जी ये तो मुझे कहते थे मैंने बिगाड़ा. So these kind of things they happen, and subsequently child improved by taking off all the medication. He was put on antidepressant, mood stabilizers only for this hyperactivity. And child actually improved with behavioral interventions. Psychoeducation. So all these things are part of psychoeducation, which is very lighter but very, very important. So which modality and why? हमें कौन सी modality use करनी चाहिए to treat ADHD and why? So when we categorize these patients into mild, moderate, severe, we see psychosocial management is integrated in every grading. Pharmacological is only mandated in moderate or more than that. Okay, and not less than 5 years of age. Recommendations are these medications should be used for kids more than 5 years of age. 5 years pe bhi kar sakte hain, but there are exceptions for that. Then when we talk about preschool, primary and adolescents, so we see that preschool children, again, in continuity that if the child is very young, we will not go for the less than 6 years of age, we will not go for pharmacological management. Otherwise, we can use both the modalities. So psychosocial interventions, kya ho sakte hain? What we can deliver. I'm not talking about Dr. Shruti is running a very good clinic here. So very systematized training centers are there. What we can tell them at our own level. Dietary modifications, very good. What diet? Additive free diet. Salicylate, I'm not sure. We have to look into the literature because I've updated this. Achha, we'll discuss this. Anything else? So environmental modifications are very important. Parental training interventions where we teach them applied behavior analysis, cognitive behavioral therapy, and cognitive training. So what parental tips we'll give? We'll actually tell them to routinize, to make a list, to make a timetable, or we see activity scheduling and try to follow that. Then what about this picture? Is it a ideal scenario for a hyperactivity inattentive child? Absolutely not. So you tell them to please have a structure around these child. They are actually having a lot of noise within them. Have a structure. So these two pictures are awful. And what about this? This kind of an you give them this seating area here. So minimum distraction. And then there should be consistency of routines and schedules. And again, a very poor kind of thing. You can just watch here and then a desktop and we ask the ADG child to sit here and study. Very, very poor arrangement. So you tell them that have a consistent routine, clean place, clean time without external noise, give them consistency and proper environment to do that. Then time breaks are very important for these children. Give them 5 minutes of time breaks every 20 minutes. That is the reference IJP. And small assignments. Subsequently, increase the intensity. Then this is applied behavior analysis. Actually, I will not go into the details of this. So these are reinforcement techniques. I think we need a separate lecture for this. What is a reinforcement? What is a punishment? We discussed it before. So these applied behavior analysis principles need to be used. We might use a different lecture for this. So you want me to discuss this? So what is this reinforcement? Reinforcement is increase of anything. Fine. And when we add a stimulus, okay, when we add a stimulus, so it becomes positive reinforcement. And when we decrease a behavior, it becomes punishment. And when, in order to actually decrease a behavior, we add any stimulus. So in increase of a behavior, we are giving a chocolate. So it becomes positive reinforcement. In order to decrease a behavior, child is shouting, we give a clap. And then it becomes a positive punishment. So similarly, negative reinforcement, when you want to increase a behavior, we remove a stimulus. रिमूव ऑफ स्टिमुलस मतलब डिजायर्ड स्टिमुलस, डिजायर्ड स्टिमुलस मतलब उसकी जो चॉकलेट क्यों ले लिया आपने ताकि वो पढ़ाई करना शुरू कर दे. So then this becomes negative reinforcement. And when we talk about negative punishment, then we remove a stimulus, है ना, and which results in decrease in behavior. जैसे है ना, जो हमने सब मारना बंद कर दिया. We actually stop hitting the child in order to so that child stops crying. So reference behavior change होता है, and so positive means introduction of a behavior, negative means removal of the behavior. So your punishment. So these things need to be basically remembered. So when we talk about reinforcement, it is increase of behavior. We talk about punishment, it is decrease of behavior. We talk about positive, it is introduction of a stimulus. We talk about negative, it is removal of a stimulus. Okay. अच्छा, which is desired? इसमें सबसे फायदा किस चीज से होता है? ये देखो हमने पॉजिटिव में यहाँ पे जो उसका टॉय था उसे दे दिया, है ना, यहाँ पे पनिशमेंट में टॉय उससे ले लिया, और यहाँ पे नेगेटिव रीइंफोर्समेंट में जो उसे मारना था वो बंद कर दिया, और यहाँ पे मारना शुरू कर दिया. तो ये कौन सा डिजायर्ड होता है? Which one you will prefer? Which one you will prefer? पॉजिटिव, पॉजिटिव रीइंफोर्समेंट प्रेफर किया जाता है, देन नेगेटिव रीइंफोर्समेंट. अगर उससे नहीं काम चलेगा देन नेगेटिव पनिशमेंट, उससे भी काम नहीं चलेगा देन पॉजिटिव. So hitting the child becomes the last option. उससे बेटर है क्या उसे मारना? So time out. What is time out? हाँ, so we need to actually ask, जब भी problematic behavior आएगा उसके साथ आपको टाइम लॉक करके उसे एक ऐसी जगह बैठा देना पड़ेगा जहां वो एक्टिविटी एरिया से दूर हो जाए. So that is time out for a specific period of time, and child needs to be isolated. So that is time out. A kind of an I would say indirect punishment. Then consistency becomes important. ये important क्यों? हम ये सब चीजें करना चाहते हैं, हम सब बता भी देते हैं पेरेंट्स को, वो कहते हैं जी फर्क ही नहीं पड़ता, कोई नहीं फर्क पड़ता. वो प्रॉब्लम is कि child would actually throw expletive, है ना, they will use a timeout. Then Dariji will interfere. Next time child will throw expletive, they will not use a timeout. So consistency becomes important. आपने कोई behavior चुनना है, उस behavior से consistent reinforcement या punishment techniques use करनी. If it is not used consistently, you will not get a response. Now coming to the medications, the business part of it. You know, so we need to actually importantly monitor the weight, height, appetite, and sleep routines. Very, very importantly, every 3 to 6 months. So this is important. And you know, stimulants approved by FDA are methylphenidate. I have highlighted the stuffs which are available in India. And non-stimulants, atomoxetine and clonidine. Clonidine also, this is extended release, but in India, extended release is not available. Guafensin is available in India. Guafensin nahi. Cup syrups mein hai. Yes. So methylphenidate, this is a very important table. Methylphenidate, they come in 3 kinds of preparations. One is immediate release or instant release. The duration of action is around 3 hours. जैसे हम लोग इंस्पिरल बोलते हैं यहाँ पे. So the plain inspiral will not act more than 3 hours. Sustained release or SR, inspiral SR, they are longish, they are not long. So they will act for 8 hours. And extended release of Oros technology, Concerta. And Concerta 18 milligrams dose comes, it acts for 12 hours. So this is how the half-life goes on. So now important is keep this data is very important. So bioavailability of stimulants is 11 to 54%. तो अब इमेजिन करिए कि जिसमें 54% बायोअवेलेबिलिटी है उसमें कितना डोज जा रहा है, और जिसमें 11% है उसमें 1/10 डोज जा रहा है. एंड so that then this around 5 times difference in bioavailability we can't predict in any child. So giving a child 5 milligram dose or 10 milligram dose instantly can actually activate the child and can cause severe reactions. That is why nowadays there is a practice that go with very, very lesser dosages. Start with 1.25, 2.5, and then titrate, because you don't know what is the bioavailability of the child. And this is a Goldilocks rule. It's a psychological principle where, you know, too much can be a problem with the child and too little can be a problem for the child. So we need to actually, you know, titrate these doses just right. book says the 1.4 milligram, 1.5 milligram per kg of stimulant is enough. So this kind of a thing we don't see in our setup. We need to actually titrate and see how child is responding, how his brain is responding, his or her brain is responding. So methylphenidate, as I shared that, so here, this is, you should not start, not here, sorry. In very rare cases, actually, before 4 years, you should start. But if the child is around 5 years of age, we have to go very slowly. Recommended age is 6 years of age. So again, as I said, begin with very less dosages, because most of the data of dosages and titrations, they are from Western population, and they actually can put you in trouble. Single dose should not exceed for more than 20 milligrams. So they are saying you actually dose it. You can give 2.5 in the morning, 2.5 early noon, and 2.5 afternoon, kind of a thing. But each single dose should not exceed for more than 20. Then total dose should not exceed for 60 milligram per day as per UK norms. But European guidelines, they sanction higher dosages. Maximum dose, sir, what is maximum dose we have used?
Maximum dose 20, 30.
Khatri sir was once telling me he using of 52 in one of the patients. I didn't go above 36. One of the patients is taking 52, but वो अपने आप ही टाइट कर लिया. Adult. Children में तो the Sanjeev, how much you use? 30, no? So as per the reported CADRA guidelines, it is 108 milligram mega dose of methylphenidate. Then long acting definitely improves adherence, because dosing a child 2 to 3 times a day can be very, very problematic for children. Timing of doses is critically important. Why? Why timing is important? Because see, the whole point is if child is going to the school at 7 o'clock in the morning, maybe the school is far away and child reaches school at 9. His class starts at 9:30, and we are giving an inspiral dose of immediate release 2.5 in the morning at 7. It doesn't make any difference. By the child reaches the school, the levels would go down. So you need to actually time those doses. So timing is very important. Child comes back to the school, child has a tuition, 2 to 3 tuitions. So you need to see what timing the peak levels of the dose should hit, so it benefits the child. Adequate trial is 6 weeks. So we can't basically shut off the dose before waiting for 6 weeks. 5 दिन 7 दिन हो गए नहीं काम कर रहा. Parents are generally very, very anxious. वो कहते नहीं जी काम नहीं कर रहा और थोड़ा सुस्त हो गया, बेचैन हो गया. But actually educate them, counsel them, wait for some time before the improvements would come. Atomoxetine, the starting dose is 0.5 milligram per kg. So maybe for 50 kg person, it becomes around 25 milligrams. The starting dose, we go with very less dose. Again, the experience is a little different because of the chances of hyperactivation. But we can increase it till 1.4 milligram per kg per day, or maximum dose of 80 milligram per day. So atomoxetine, what is the problem? What monitoring need to? Very, very important. Liver function tests need to be subsequently seen. And atomoxetine trial is like any other antidepressant trial. This 12 weeks. Clonidine. So clonidine, the dosages, again, we can go to 400 micrograms. It is reported, but you have to go slowly and titrate it 50, 100, then 150, 200, 250, 300, until 400. We can see we have to monitor the blood pressure of the child, which is difficult in our setup. So we need to help our pediatrician friends so that they have a pediatric cuff and we can monitor the blood pressure for the child. So there are a lot of side effects of stimulants. I will not go into the details because then it will, because it is in itself a lecture in a different sense, but it definitely would suppress growth and appetite, but they are reversible. They say that after some time it recovers. Then there is an controversy that it worsens tics, it worsens seizures, it increases emotionality, behavioral rebound is there. Behavioral rebound means आपने सुबह स्टिमुलेंट दिया, शाम तक बच्चे का बिहेवियर फिर से हाइपरएक्टिविटी या इरिटेबिलिटी आ गई. Sleep disturbances, giving stimulants in the morning, child is not able to sleep. Abdominal discomfort and minor increase in pulse rate and blood pressure. That day one patient came, he said, ये तो stimulant ऐसे खा के तुम और नींद आ जाती. ये कैसा stimulant? So I asked him whether you drink coffee and sleep. He said, yes. So how you explain this? So many a times stimulants would reduce noise in the brain and it helps you to sleep because of the noise you're not able to sleep. So similarly, coffee reduces that noise and then you go into sleep. So there are few explanations which people have given us. Then drug holidays. These are very important concept. So अगर tolerance develop हो रहा है तो हम drug holidays देंगे तो tolerance खत्म हो जाएगा. So we need to see कि बच्चे का जब school time है, vacations हैं, या extended holidays हैं, we immediately can stop these stimulants. And the benefit is it can interrupt the development of tolerance. Monitor whether medication is effective. Parents at times think कि जी हमने तो बंद की तो फर्क नहीं नजर आया. At least the medication are not working. Then child might not take stimulants because stimulants can suppress your creativity or your energy levels, and the child is not able to play the favorite sport like hockey, badminton, football, or something. So you would want to take them away to actually let the child play. And when we see that acute effects, appetite and growth after giving a drug holiday, child starts to recover those lost metabolic demands. Now, dietary interventions, as Dr. Ishani has pointed out. So, dietary interventions, they say that there are three kinds of diets: elimination diets, which are exclusion of items associated with hypersensitivity, and fatty acid supplementations, and exclusion of food colorants, additive items, which she said. So, we see that the evidence is of all the two types. Elimination diets, there is not much evidence. They said you can give fatty acid supplementation. This is as per this meta-analysis in 2013. I don't know whether what is the recent data. We should check it out. But coloring items should be avoided. कितने दिन तक आप stimulant रखेंगे? What you will tell? Very difficult question to, and we have to face this question from every patient, unfortunately. So how much? Any idea? बच्चा आया है 6-7 साल का, आप बोल दो लाइफ लॉन्ग चलेगा, पेरेंट्स बहुत देंगे. So what you will tell them? You tell them that first of all, there are no clear guidelines. The aim is to maintain the medication until child's maturation and cognitive skills makes the medications unnecessary. आपका growth burst आ गया बच्चे का, child becomes better, wouldn't require subsequent growth, maybe you can take it off. Clinical experience suggests that most children who benefit require a long period of treatment over several years. So maybe it can go for a long period of time. But status needs to be reviewed every year. So what we say is stimulants in context of stimulants, we have to review it. Probably next year we'll see whether we'll discontinue or not. If the child is symptom free for 1 year on medication, we can think of stopping. When to stop? The maximum leisure time is there. The minimum demanding time, like post exams, we can stop. Choose a low stress time to stop medication. That is after exams. Then your Rutter says that periodic off periods, 2 weeks every 2 months can be given to test whether child has achieved that maturity, and then we can take off these drugs. COVID-19, yes, COVID-19, the attention deficit flared up, and a lot of children, it was very difficult for parents to manage them because they needed open atmosphere to run away and expend their energy. So it became a challenge. Stimulants were subsequently banned from giving online prescriptions. It became a challenge for these children. In few countries they legalized it. In India it was not legalized. Very, very challenging. So what when we say that ADHD is remitted, because if there is lack of any need to adjust dose, despite robust growth, lack of deterioration when a dose of stimulant is missed, and newfound abilities to concentrate during drug holidays are achieved. So now important last slide is important things to remember. Nothing succeeds like success. So whatever, there is no clear-cut formula. Need to again go with realistic goals. Work hard on self-esteem of the child, parents, and the family. Highlight strengths and abilities of the child. Never focus on the weaknesses. Work with again the systems. Modify plans. Not be very strictly with one plan. It is a dynamic process. No therapy is better than another. PG, dawai nahi, psychotherapy, psycho nahi. That is never the right approach. And timely combinations are always better. So you need to be very, very fluent with your approach. The rigid approach will be an issue. So these are all signatories, that the VIPs who actually had ADHD. Thank you. So I sign off with Michael Phillips, who actually managed to win so many gold medals. The child threw them at swimming pool. Someone suggested them, and he actually became a champion. Thank you. Any questions?
Any question?